Yes.
Shall I start, sir?
Can you hear me?
Yes, please. Yes, we can. Yeah. Karen, you can start, I think. You can start, right? Pradeep?
Today Dilip will be presenting and moderated by Professor Harjeet, Professor Sudhindran, and Professor Sadaf Ali. I think it's all yours. You can take over now.
Yeah, Pradeep, Dilip, please carry on. Start your presentation.
Okay, sir. Sir, here is a 55-year female patient. She is a homemaker, resident of West Bengal, came with the complaints of pain in the right upper quadrant past 7 months, and loss of weight and loss of appetite in the last 3 months. Yellowish discoloration of eyes with fever in past 1 month. In the history of patient was apparently all right 7 months back when she noticed pain in the right upper abdomen, dull aching, intermittent, non-radiating, and not associated with any aggravating factors and relieved with over-counter analgesics. She also gives history of yellowish discoloration of eyes and sclera with eye-colored urine in the last 1 month. But it is not associated with generalized itching or clay-colored stools. She also had low-grade fever, not associated with chills and rigors. She consulted local physician for the same complaints and underwent few blood investigations and took symptomatic medications, following which fever resolved. She also gives history of loss of appetite with loss of weight, which is not quantified since the last 3 months. And there is no history of vomiting or nausea, no history of similar complaints in the past, no history of any transfusion of blood or blood products, no history of abdominal distension, and no history of melena or hematemesis, no history of mass per abdomen or palpable swelling elsewhere. Past history, there is no history of any previous surgeries, no history of any comorbidities, and family history is not significant. And on personal history, there is no addiction, sleep is adequate, appetite reduced, bowel and bladder habits are normal and regular. So to summarize the history, here is a 55-year-old female with no comorbidities, resident of West Bengal, presented with right upper abdominal pain with loss of weight and appetite. So since 7 months. The developed jaundice from last 1 month, not associated with itching or clay-colored stools, with low-grade fever, which resolved on medications.
So last 1 month after she developed jaundice, she has not had any tests?
Sorry, sir?
After she developed jaundice, did she have any tests at all?
No, sir. Only she underwent some, when she got fever, she has done some blood test and taken treatment on OPD basis only.
So what do you think, Dilip? What are the possibilities? Yeah, sorry, sorry, what were you saying?
Yeah, I asked him what you said. What settled down was only fever, na? Not jaundice.
No, fevers.
Jaundice
Yes,
was not intermittent. Okay, fever. So sir is asking what would be your initial differential few diagnosis based on history?
Based on the history, my differential diagnosis would be first in the order of preference. It could be malignant surgical obstructive jaundice, ma'am. And the first possibility may be carcinoma gallbladder, and the second is pancreatic head carcinoma, and ampullary carcinoma followed by cholangio carcinoma. If benign cause, if we consider Mirizi syndrome is one of the probable, ma'am, with less priority.
Why do you say she has got obstructive jaundice?
Sir, it is from the actually the patient doesn't have any.
How will you differentiate? How will you differentiate hepatocellular jaundice from an obstructive jaundice clinically?
Clinically, in obstructive jaundice, usually there will be clay-colored stools or itching, sir. But
Has she got that?
no, sir. In this case, it is
Then how
not.
can you say it's obstructive jaundice?
Sir, one is
obstructive jaundice is a non-starter for you. It's not obstructive jaundice from the clinical history.
clinical history, yes, sir. But
You cannot make any of these diagnoses as your first diagnosis. Had she had itching or clay colored stool, it's a different matter. Then it's obstructive jaundice. In the absence of those two, it is not obstructive jaundice. Your first clinical diagnosis will be hepatocellular jaundice, isn't it? What are the points against it? What are the points against hepatocellular jaundice?
Sir, here the history of the pain is preceded over the other symptom jaundice, and it is the long duration, sir, 7 months, and the loss of weight and loss of appetite is there.
So presence
So
of
if
pain is the main
preceded,
factor.
it's all the more.
Yeah, carry on.
If
Please
the
carry on.
if the pain precedes, all the more not an obstructive jaundice. What do you other point other than clay color stool you say classically about obstructive jaundice? You said the pain was significant, was there for quite some time.
Yes.
But in general, we say no, it's a progressive, painless jaundice.
Progressive. Yes, ma'am. In painless progressive jaundice.
So all your sir is saying that all your things are not fitting into what you're trying to put first.
Yes. Usually, the painless progressive jaundice is more in favor of the malignant surgical obstructive jaundice, ma'am. In gallbladder carcinoma and in the pancreatic carcinoma can be associated with the pain.
That
But here,
advanced.
yes, ma'am. Here the
So
duration.
in your differential diagnosis, the surgical obstructive jaundice will not come in first. I'm sorry to say. If you look at it, looks like a more medical jaundice. And malignant, why do you say it's malignant?
So one is it is a loss of weight, loss of appetite is there, sir. And
Although you do say it's not significant, you yourself have said it's not quantified.
Yes, sir.
Yeah. So how do you quantify significant loss of your weight?
Sir, even if there is increased bilirubin also, that may also decrease the appetite.
Yeah. So when will you say weight loss is significant? MBBS
When
question.
More than 10%.
Yeah. So has she got that?
No, it is just given as unquantifiable, sir.
Yeah. So both your malignant and your surgical obstructive jaundice as first differential diagnosis is a bit far-fetched, I have to say. What could be? Just think again. So if it's a hepatocellular jaundice, what are the possibilities? Just because you're a surgical team doesn't mean that the diagnosis has to be surgical all the time. Suppose this patient comes to the clinic.
Yes, sir.
What will be your first? What will be your thoughts?
Sir, we have to rule out the hepatitis cause also, sir, like hepatitis.
Absolutely, yeah. So maybe some sort of subacute hepatitis is a possibility. What else?
Hepatitis A and hepatitis B, we have to.
Whatever, some sort of hepatitis. Subacute hepatitis is a possibility because it's been going on for about a month. What else?
And or only onset of fever is only mild fever that to resolve on medication, sir. So the other causes for jaundice, like any abscess, liver.
Abscess, okay, yeah.
But
chronic liver disease is a major possibility.
Yes,
but
sir.
likely she may have chronic liver disease. It's been going on for some time. Loss of which is jaundice and doesn't seem to be obstructive.
Yes, sir.
All right.
Sir, in this case, there is no history of addiction also, and there is no and retrospectively there is
what
even
addiction?
Alcohol.
Yeah. So what are the other causes of CLD other than alcohol?
Alcohol, hepatitis B, sir, or fatty liver disease.
Yeah.
Or hepatitis C.
Also, also PBC, PSC, which is more common in women. So NASH, PBC, PSC, all these are possibilities that could be there.
Possibility, yes.
Then what about CBD stone? Minutes you have mentioned.
Sir, choledocholithiasis, Usually for the period of 7 months, and it is not typical biliary colicky type of pain, sir. And the jaundice is not intermittent.
So what is a typical biliary colicky type pain?
Colicky type pain, usually the pain comes intermittently and aggravated on taking fatty meals, and usually it will resolve within 6 hours.
So how is this pain? This lady's pain, how is it?
Dull aching type of pain, sir.
So, so is biliary colic a colicky pain or a
No, sir.
dull
This
aching
is
pain?
misnomer, sir. It is not a biliary
So is
colic.
biliary colic a colicky pain?
No, sir.
It's a
So
misnomer.
you,
It's still a dull aching
Dilip,
pain. Yeah, carry on.
Dilip, you said that patient will have a pain which is for 6 hours or something. It is for the CBD stone or a gallstones? This typical pain is for the CBD stones or gallstones?
So typical biliary colic we will see in gallbladder, sir. But it can be there in.
So does the Mizdi syndrome can occur without gallstone? You said no, the pain is not typical a biliary pain, but you made a diagnosis of Mizdi syndrome.
Yes, sir. Sir, Mirizi syndrome I have done because there is it can be because of gallstones also, sir, because the long duration of the pain, and she has taken repeatedly.
It can be or it is always?
It is, sir, always.
And one more question. One suppose it's a obstructive jaundice, because I think from history we cannot clearly say that it's a obstructive jaundice, as Dr.
Yeah.
Sudhindran said. But suppose it's obstructive jaundice, how will you explain that there is no clay-colored stool and pruritus? What could be an explanation for this?
Sir, even in obstructive jaundice, in all cases, there won't be, if it is not.
So what is the reason for
if there is no
obstruction?
complete obstruction? Then
so what is your initial differential diagnosis were carcinoma gallbladder and pancreatic head carcinoma. So what is the odd in jaundice part with which
Yes.
you cannot explain this diagnosis?
That is, there is no clay colored or
So
pruritus.
usually the CA gallbladder, they tend pancreatic head carcinoma, they tend to do the complete obstruction.
Obstruction, yes.
Well, I think the same question,
Sir,
why
there's
you
one,
did not. Yes, sir.
Please carry on. Carry on.
And second, yes, you said Mirji syndrome. Why not CBD stones? The same question.
Sir, CBD stones, patient has complaints of 7 months history, sir. Usually the choledocholithiasis will not, the clinical course won't be like this, sir. So Mirizi syndrome, mostly the gallbladder, in Mirizi syndrome, initially she may be having gallstones, which initial episodes may be biliary colic. Later it progressed into the Mirizi. That's why I've kept as Mirizi Hilar rather than choledocholithiasis.
And that is true for the carcinoma gallbladder and pancreatic head carcinoma also, because the course will not be like so benign in this disease for 7 months. But you kept these differential on the top.
Yeah. Yes,
So Dilip, I think you're mistaken that as soon as the stone comes into the bile duct, that day you'll get the symptoms. Of course not.
Yeah. Yes,
So
sir.
the symptoms can be like 6-7 months symptom is not at all unusual in the CBD stone. So there's one question in the QO thing. Could it be intrahepatic cholestasis? So the question is, how do you differentiate? I mean, it is not obstructive cholestatic jaundice, but suppose it is cholestatic jaundice. How can you differentiate intrahepatic from extrahepatic cholestasis?
Sir, in intrahepatic.
Let me rephrase the question. What are the causes for intrahepatic cholestasis?
Sir, intrahepatic cholestasis, it can be because malignant causes like intrahepatic cholangiocarcinoma or hepatocyte.
No,
Sclerosing.
no. Those are all extrahepatic, isn't it? They talk about obstruction outside the cell, outside in the biliary tracts. So that will be, if it's in the biliary tract, then it's an extrahepatic. So intrahepatic means it's a cellular cause. There is delay in excretion of bile from the cell into the biliary canalicula. That is intrahepatic cholestasis. But the symptoms of intrahepatic and extrahepatic will be exactly the same, which is, as we explained before, itching and clay-colored stools. Both will have severe itching, both will have clay-colored stools. But what are the causes of intrahepatic cholestasis?
It can be
At cellular level. What all
cell-
disease it could get?
primary sclerosing cholangitis.
Correct. So any CLD can be, particularly the
And
cholestatic liver disorders
NCLD
like
more
PSC.
commonly.
Yes.
Yeah. What else?
And because of
Other cause of hepatitis. For example, simple hepatitis, drug, they all have a cholestatic phase. It could be drug-induced hepatitis,
drug-induced hepatitis.
alcoholic hepatitis. All these are cause of intrahepatic cholestasis. So the
Yes.
predominant, what about extrahepatic cholestasis? They all usually, as we say, surgical causes, CBD stones, or benign stricture or malignancies. So in all those, the usual thing will be the history. The history will be usually a pain, or they have some previous procedures, like maybe because of a stricture. The other one, you have more signs of drug induced alcohol intake or symptoms of CLP. So that is how you differentiate intrahepatic from extrahepatic. Okay, I think we can carry on. But differential diagnosis, be very, very careful. I think this will come. All this will come. Definitely it will come. But after the first one, that is a non-cholestatic jaundice, then all this will come.
Yes.
Okay, carry on.
On general physical examination, patient was conscious and oriented to time, place, person, and moderately built and nourished. ECOG status 1 and BMI 22 kg per meter square. The breath holding time is 42 seconds. The pulse 76 beats per minute with BP 100 by 60 mm of He. Respiratory rate 15 beats per minute. Icterus was present. No pallor, cyanosis, clubbing, or pedal edema, lymphadenopathy. No signs of liver cell failure. No left supraclavicular lymphadenopathy, and no visible scratch marks. On per abdomen examination, the abdomen is flat and umbilicus is central and inverted. The all quadrants moving correspondingly with respiration. No visible scars or engorged veins. Hernial orifices and genitalia appears normal. The renal angle appears normal. Back and spine appears normal. On palpation, the abdomen is soft and non-tender. The liver and spleen are not palpable. No palpable lump, and no cough impulse or hernial orifices. The percussion, the liver span is 14 centimeter in right midclavicular line. The flanks are tympanic. On auscultation, normal bowel sounds heard. On digital rectal examination, gloves stained with normal feces and the normal sphincter toe. So the respiratory system and cardiovascular and CNS were normal. No signal. So to summarize the on examination, a 55-year-old female with no comorbidities, resident of West Bengal, present with right upper abdominal pain with loss of weight and appetite, developed jaundice since 1 month, not associated with itching or clay-colored stools, with low-grade fever, resolved on medications. And she is moderately nourished female with icterus and no other positive findings on examinations. So
what is your differential diagnosis now?
Sir, again on examination didn't yield any significant findings, sir. So the differential diagnosis will be first is it can be hepatocellular jaundice or it can be surgical obstructive jaundice, sir. The first may be malignant obstructive jaundice.
But why malignant obstructive jaundice again? Why that's the first diagnosis?
No, sir. First diagnosis hepatocellular jaundice and followed by the obstructive jaundice. In obstructive jaundice, it can be malignant or benign.
If it's malignant obstructive jaundice, what is your diagnosis in order?
Sir, in malignants, I'm first keeping priority the gallbladder carcinoma, sir, followed by carcinoma of pancreas. Sir, gallbladder carcinoma. So one is the right upper quadrant pains in 7 months. Resident of
what is the most important negative clinical finding in your abdomen?
Especially after you have given the summary of your examination and you did not pick up anything.
Yes, ma'am.
So you have to talk in that light as well. You haven't palpated a
What's the most important negative finding? Yeah.
So, there is no palpable lump or palpable gallbladder mass, sir, on clinical examination.
So how often is curvaceous law applicable in a malignant obstructive jaundice?
Sir,
How
in
often do you find a
Curvoisius
palpable
law,
gallbladder?
yes, sir. In Curvoisius law, in head of pancreas, only it will be present from 13 to 17%, sir. It need not to be always palpable gallbladder in carcinoma head of pancreas.
Why is that? Why is that?
Sir, in Curvoisius law, the palpable in carcinoma head of pancreas, the palpable gallbladder is present in 17%, sir. 14 to
Why is
17.
that? What happened to the remaining 83%?
As it sometimes it may be not palpable also, sir.
Why?
Sir,
I don't know. Is that true, Harjeet and Saudar? I didn't know that.
No.
The main
No,
reason it is
it's not.
actually
That's not
distant,
correct.
but it may not be
Yeah.
It's not
palpable. That's all. It may not be palpable. But if you look at the ultrasound, it will be a distant gallbladder. It's not palpable because the gallbladder is under the liver.
and
So it just may not be palpable. That's all. But it's distant. More than
yes,
70% will be distant in the head of pancreas. That's what I thought. Maybe I'm wrong. Correct me if I'm
Yes,
wrong.
exactly. No, it's right what you're saying.
And
It's
Dilip,
getting
Again,
you
if
said
confused
you
with
tell-
stone disease.
sir.
Dilip, you
Sorry.
said there is no positive finding in the examination, but still there is a hint in the examination in which I think you should not be keeping because we are debating why malignant jaundice, why CAGB or pancreatic head carcinoma on the top. So there is a hint in the your examination
Yes,
which
sir.
will help. Yeah. So what is those point in which we can say that this is not a carcinoma gallbladder or this is not a pancreatic cancer? Is it possible in the carcinoma? Do you routinely see carcinoma gallbladder patients? Is it possible that patient will have a 7-month history of a pain abdomen and then anorexia, weight loss, and jaundice of
gallbladder-
1 month, and patient will have a
Yes,
ECOG1
sir.
status and well-preserved
Very
patient, and
less
you are,
likely.
so I think these
Gallbladder
are a
carcinoma.
very even headopancreas tumor, they doesn't have a so benign course that the patient is absolutely all right, almost all right for 7 months, and there is the jaundice is even on examination you see that the stool color is normal, so that means obstruction is not complete.
Yes, sir.
So these are a pointer which
Dr.
I think
T-
against.
In this case, why I have considered carcinoma gallbladder is because the carcinoma gallbladder may be in the advanced stages because of, even if it is in the body and fundus, if it is carcinoma gallbladder, then it can also cause
Then why there is jaundice?
In the later stages, it can cause the lymph node enlargement, sir, in the retropancreatic region, which can cause obstructive jaundice. So I thought that's why carcinoma gallbladder I have considered, sir. In the advanced
What is the
stages,
Corvoisius law? Professor TD Yadav is saying this, define the law properly. What is Corvoisius law?
Sir, in an obstructive jaundice, when there is a palpable gallbladder, it is due to the carcinoma head of pancreas or periampullary carcinoma. Sir.
No, that's not the law. That's not the law. What is the law?
In an obstructive jaundice, when there is a palpable gallbladder, it is due to the malignancy, sir, like carcinoma head of pancreas.
No, it's the other way around. No, it's a negative thing. In an obstructive jaundice, if gallbladder is palpable, it is unlikely to be due to a stone. It is a negative thing. Because why it's not palpable in a stone? We're going back to the MBBS classes now.
Sir, if it is
not due to a stone.
Sir, in the stone disease, usually it is a long duration, sir. So the gallbladder will go for fibrosis, sir. So
yeah. So in this case, again, after clinical examination, your first diagnosis should probably be cholangitis, gallbladder, Meritz or Meritz is again, or CBD stone. That should be your first diagnosis. Then, if you're talking about malignant jaundice, you give the diagnosis where the gallbladder is unlikely to be palpable. Which would be sort of cholangiocarcinoma, over there, cystic joints, and then you come to the other ones. All right. And then you can say even in CA pancreas or periampullary carcinoma, although gallbladder is distant, it doesn't have to be palpable. All right. Okay, go on to the next. What will you do? Investigations?
Sir, first I will do the ultrasound abdomen along with the blood investigations.
No bloods. Okay.
CBP, LF.
Okay, blood test. Do you have the results?
Yeah, they'll share it.
What all blood tests do you want?
Sir, CBP, LFT, and the renal function test. I will do. So the hemoglobin is 12.2 and total counts within normal and platelets also normal. Sir.
So what can you make out from this? What can you rule out from
There
this?
is cholangitis. There is no evidence of cholangitis. Usually in cholangitis increased. And the platelets also, if it is CLD, platelets will be
correct.
decreased.
Yeah, absolutely. It's very important, platelet count. So chance of chronic liver disease is unlikely. Okay, go to the next one. Next investigation. LFT, RFT, LFT.
Yes, RFT within the normal limits, sir. And the LFT, the total bilirubin is 4.3 with direct 3.1, sir, increased. And SDOT, SGPT 224 and 277 increased. Alkaline phosphatase is 401, it is increased, sir. Albumin is within normal limit. And PTIN are also normal, sir. So it is going in favor of obstructive jaundice with cholangitis features.
Why cholangitis?
Obstructive jaundice?
Sir, obstructive jaundice direct. Yes, sir, 3.1 and alkaline phosphatase is increased, sir, 401. And since there is increased in SDOT and STPT, and it is elevated 3 times, sir. So cholangitis also.
So where all can alkaline phosphatase be produced?
Sir, alkaline phosphatase can be produced by different organs also, sir, like a bone or cardiac and liver.
Cardiac?
Yes, bone mainly. The other source of alkaline phosphatase is.
I didn't know heart could produce it, not that much.
Yes, I've read. Yes.
Bones, kidneys, intestines, white cell count, all this can produce alkaline phosphatase. So if you have kidney disease, you can have high alkaline phosphatase. Bone disease, you have high sepsis and high white cell count, sometimes you can have alkaline phosphatase. So how will you know it's definitely obstructive jaundice or not? What are the tests do you do?
Sir, GGT we can do, sir, which is
along with GGT. Have you done GGT?
Gamma glutamate.
Not done, sir.
Have we done GGT?
No, sir, not done.
They're saying.
No, yeah. So from this clinical picture, what will be your diagnosis? Suppose this is a clinical picture. This is your blood test.
Yes, sir. It is in the. Sir, it
anything is actually strikingly coming into your mind that 1 month history, the bilirubin is around 4 or 5. So how can you take it now ahead with some amount of transaminitis as well as obstructive element?
Yes, so it can be obstructive jaundice with cholangitis, sir. At the time of April, it is done in April.
He's asking what could be the likely cause. You look at this, just this big picture.
1 month, with 1 month history, we can consider. One is it could be because of Mirizi syndrome, or it can be because of malignancy also, sir.
So you're thinking on lines of Mirizi means there's a partial obstruction, huh? So you're thinking on lines of partial obstruction. Can you classify it further? What all partial obstructions you can add to your diagnosis? So thinking a part of it is flowing and the part of it is getting obstructed. Is it so? So yes, that 1 month, the jaundice is not, classically progressive and high as your placed first few differential diagnoses, like it should happen in any distal cholangio, CA, and pancreatic head and periampullary tumors. Yeah, yes, the performance should not stay that good in, as Harjeet said, that in CA head of pancreas and CAGB with obstruction. Your bilirubin 5.
Yes, ma'am. I mean, in ampullary carcinoma, there may be the intermittent jaundice may be there, ma'am. And also in choledocholithiasis, if it is not completely obstructed, even in that one, there may be decreased in bilirubin in between. Whereas
so
in
that differential diagnosis are brought you to choledocholithiasis. Why don't you consider?
Yes, ma'am.
Okay.
I agree. I think looking at this, that will be a first diagnosis. I don't know why you keep on saying Miritzi. How do you make a clinical diagnosis of Miritzi? Which one is more common, Miritzi syndrome or cholangiocolithiasis?
Cholangiocolithiasis.
Yeah, so why do you keep saying Miritzi?
No, sir.
Please never ever say such
Okay.
difficult and rare diagnosis. You cannot make a diagnosis of Miritzi by this one. You can say cholangiocolithiasis. It's very, very typical, no? Because low bilirubin, SGPT is raised along with alcohol. This is a very, very typical diagnosis of a cholangiocolithiasis.
Cholangiocolithiasis.
All right, carry on. Next, what would you do? But how will you? Yeah, carry on. Next,
Ultrasound abdomen, sir.
ultrasound. Yeah, very good. What do you specifically look on ultrasound?
Sir, in
What is it you want to
ultrasound,
look at?
sir, in ultrasound, whether there is, how is the gallbladder, how is the CBD, whether there is any intrahepatic biliary dilatation, or what is the level of obstruction, and any other findings such as ascites and liver echo texture, all those, any mass, I have to assess, sir.
So the most important thing that you look at is the intrahepatic biliary dilatation. So once you find that, then obviously your diagnosis will go into completely different picture. It becomes a surgical jaundice. Then it becomes an extrahepatic obstruction. How long does it take for the intrahepatic biliary radicals to dilate once the bile duct is obstructed?
2 weeks.
Yeah, it's only 1 to 2 weeks. By that time, even by 1 week, your central intrahepatic biliary dilatation will happen. By 2 weeks, your peripheries will also dilate.
Right.
So that will be the very number one thing that you look at. Then, of course, all the other things that you said. Okay, ultrasound finding.
And Dilip, when you are asked what you want to see in the ultrasound, I think there is a way to explain that how you should explain the ultrasound finding which you are expecting. Either you go from top to bottom or from bottom to up. Okay,
Yes.
You cannot be haphazard. Like if you should start with the liver, then IHBRD, then you can see for the gallbladder, CBD, or both. So I think that's not a correct way that once you will explain liver, then you will go to the CBD. So there's a way to explain these findings.
Yeah, that's right. I think you all have learned that the typical protocol must be learned by heart. So what do you make of this?
So you have these findings of ultrasound. Just go through and read for all of us. What are you seeing on ultrasound reporting?
Liver mild increase in the size and normal echo texture with smooth contour. The left lobe of the liver reveals a solid lesion measuring 5.2 into 3 centimeter with vascularity on Doppler. Mild to moderate bilobar IHBRD noted predominantly in the left side. Visualized CBD appears normal. The gallbladder well distended and lumen is echo-free. The wall thickening is normal. The pancreas and spleen normal in size and echo texture. And both kidneys normal and corticomedullary is maintained. No ascites, no lymphadenopathy or effusion.
So what do you think now based on ultrasound?
Here, the left lobe, there is some solid lesion, ma'am, but there is bilobar IHBRD noted. So the obstruction may be in Hilar. Again, here one more negative this thing is gallbladder is well distended. If it is Hilar cholangiocarcinoma, usually the gallbladder will not be distended, ma'am. So with these findings, but the negative this thing is the gallbladder is well distended. Otherwise, it looks like Hilar cholangiocarcinoma.
So if it doesn't fit into that, what else can you add beyond Hilar cholangiocarcinoma? You put few things more than. Okay, you said this is against you, so you're putting it out. No, you're not keeping it as a Hilar or a peri-Hilar immediate carcinoma.
Yes. One is that one, ma'am.
That is what I was saying. That is there a partial obstruction? You kept on saying meriscus.
Yes.
Again, the gallbladder is getting filled because of partial obstruction.
Yes, ma'am.
And how will you explain that left lobe lesion in Hilar cholangiocarcinoma?
Yes, sir. That is That is one of the points, sir. And the second one is it can be because of distal obstruction also, like distal cholangiocarcinoma with any left lobe, or again in ultrasound, again we have to evaluate that left lobe, sir, whether it can be metastatic also.
So why there is
Okay, wonderful.
why there is a more predominant HBR on left side, not on right side?
Yes, sir. That's what I thought. It's Hilar cholangiocarcinoma with
I think you have
extent
to take a complete picture, okay? Then you make your differential diagnosis. There is a lesion in the left lobe of the liver. There is bilobar
Would you like to
IHBRD, and
evaluate it further?
Yes, ma'am. Because it's I have to evaluate further.
So 1 second, do you think this was a fasting ultrasound or a fed ultrasound?
Most it is fasting. I'm not
Why do you
sure.
say that?
So gallbladder is
What happens to the gallbladder in the fasting state?
Gallbladder distended.
Why
sir.
do you ask people to come fasting for ultrasound?
To look for because the gallbladder should be distended to evaluate.
Yeah, so that explains the distant gallbladder. No, it's nothing to do with the lesion below that. Just a normal distant gallbladder if it's done in a fasting state. You don't have to give too much of thing into that because you cannot see the visual CBT. It is normal. You clearly said that.
Yes.
Obviously, there's no lesion beyond that. It's very unlikely. So, what's your next investigation? What would you like to do?
Sir,
What would you like to do?
MRI.
MRI. Okay, MRI. Okay. Have you got an MRI? We don't, I think.
only MRI or something
Yeah, what
special in
MRI?
MRI with MRCP with contrast also. With contrast, I will see, sir, to assess for the vascular involvement.
So I think that is very important when you're asking for an investigation. Just completely explain what you want. Do we have MRI?
Dilip, you have controls.
Yeah.
Dilip, what do you want to see first?
Yes, sir. So first I
You
will
have
see
given
the
all phases, everything. So what do you want to see first?
sir T2 weighted image. I will see, sir. T2 weighted image. In that one, I will see. This is the T2 weighted MRI, where we can see the dilated intrahepatic biliary radicals with more on the both. It is a bilobar intrahepatic biliary dilatations are present with left more than the right, and also there is a in the Hilar region. This is the right biliary system, and this is the left biliary system. At the Hilar, there is an mass which is extending into the left lobe of the liver, almost till the capsule. And also,
Which segment it is over there?
again, it looks 4A, 4B, ma'am, but I have to see the total face to confirm the segments. And also there is crowding of the biliary duct in the left lobe. Here.
Do you think Dilip, do you think the portal vein? Can you comment on the portal vein?
Portal veins.
No, on this one, on this particular image.
In this
I know it's not contrast.
Yes.
Do you think it's thrombus or is it patent? How can you know?
Sir, that in the region we can see the hyper intense
What is the black thing that you see there? That black, yeah, where you have arrow. What is that? That black, yeah.
What happens in T2 phase to the biliary duct and to the portal vein? Why the bile ducts are white?
White, because that biliary in T2 it will be hyper enhancing.
Why?
Sir, hyper intense.
Why?
So the portal vein, that is actually called the flow void, isn't it? In the T2, the flowing structures, for example, although blood is full of water, it still appears black on T2 image because it's actually moving. It's called a flow void. You can actually see the flow void in this. Let's go up a little bit more. But come down a bit more to see the left side of the portal. Can you come down on the CT?
Yes.
On the no, a bit more. Yeah, you can see that right. Yeah, there. That's the flow void. You see, on the left side you can see, on the right side you can very clearly see the anterior and the posterior branch, the portal vein, and the left side also. The left portal vein it looks compressed actually, but it's the flow void is there. It's not thrombosed. If it was thrombosed, it would have appeared white.
Yes.
Okay, go to the.
And gallbladder is distended, sir. And the other findings are the right lobe. There is no evidence of any lesion.
You can go for the contrast CT, I think. I mean the contrast MRI now.
This is the contrast MRI, sir.
Is contrast MRI T1 or T2?
Only portal it is mentioned.
Is contrast MRI T1 or T2?
T1. T1,
yeah,
sir.
Very good, yeah.
It is not coming like. These are the hepatic veins, sir. The right middle, the left. There is bilateral intrahepatic biliary radicals, and this is the right portal vein, right anterior and right posterior. And this is the left portal vein, where we can see the enhancement, but it is here it is narrowed in the left portal vein, sir. Here it is the left portal vein. Here it is narrowed, sir. And the rest of the portal vein appears to be normal.
Do you think there is chronic liver disease?
Chronic, no, sir. Liver parenchyma appears to be normal, sir. There is no deepened fissure or these things are only except the left side. There is crowding of intrahepatic biliary radicals. The right lobe appears to be this part. It is crowding of intrahepatic biliary radicals are there, sir. But in the right appears to be normal, sir.
Is there caudate lobe hypertrophy? It's an important finding, no?
Yes, sir. This is a caudate lobe, sir. Yes, sir. Yes, sir. This is the caudate lobe, sir. Hypertrophy is not that much.
Okay, so not much.
And there is.
What about the artery?
Arteries. Sir, a distal CB. Yeah.
The arterial phase, no?
Yes, sir.
Arterial phase, yeah.
This is the arterial phase, sir. And this is the left hepatic artery. Narrowed. So it can be type 3B Hilar cholangio, sir.
Or does it look a little more well beyond the secondary branching? If you reconstruct it, it looks more beyond that. what you're saying, the block. Some amount of little.
Yes, ma'am. Yes, ma'am. Here it is little narrowing is there on the left side, ma'am. So, but here the dilated behind the secondary biliary radical, there is more dilated intrahepatic biliary ducts are there, and crowding of ducts are there, and distal CBD I want to say, and distended gallbladder, and the rest of the distal CBD appears to be normal.
Would you want to look at the diffusion weighted images?
Diffusion restricted. Yes.
What would that tell you?
Sir, if there is a malignancy, there will be a diffuse restriction will be there, sir. In
And how will it appear?
cholangiocarcinoma. It helps to
How will it
differentiate.
appear? Is it T1 or T2? Diffusion weighted images.
Diffusion restriction. T1, sir.
So all these special images, they're all T2. Most of them, diffusion weighted, in phase, out phase.
Yes.
All those are T2 weighted. So it's T2 weighted images. Basically, it's in a malignancy or a major infection, etc. Because the movement doesn't occur, they will all appear white. That's the thing. So compared to, for example, you wrote FNH or some other benign lesions, not adenoma, that'll be a good thing to diffusion weighted images. It'll appear white.
White.
Okay, so you want to do anything else? Are you happy? What is your diagnosis now?
Now, yeah, it can. Type 3 Hilar cholangiocarcinoma. Type 3B Hilar cholangiocarcinoma, sir. With the no involvement, with the left portal vein involvement, and no, the right portal vein, right hepatic artery appears to be normal, and the right lobe 5, 6, 7, 8 segments appears to be normal, sir. And the middle vein, hepatic vein is normal, and
Then what
and
is that segment 4 lesion?
Then why
there is a segment 4 lesion is there? What is that segment
Right.
4 lesion?
and
so he wants to put it the other way? How frequently do you see a mass forming hilar or perihilar cholangiostriae? When a hilar cholangiostriae, which is directly starting from your, it's type 3B classification is hilar involvement and beyond, na?
yes, ma'am. Usually cholangiocarcinoma, the mass
So
forming
you
is
saw a sparing kind of a hilum over there. Would you think
Yes.
on some more diseases as well in and around that area?
it can be intrahepatic cholangiocarcinoma.
Okay.